Good evening, everybody. Welcome to another ESG Wednesday webinar. Tonight, I think we have a great topic, and I'm going to invite on screen right now Professor Lorenzo Fuccio and Dr. Sandra Nagl, who are going to be joining me, who are outstanding speakers. We're going to be talking tonight. Sandra and Lorenzo, there you guys are. Welcome. Tonight, we are going to be talking about endoscopic management of esophageal and gastric variceal hemorrhage. We're going to be talking about tips and tricks. Guys, I don't know if you know this, but this is a record-setting webinar. We have over 1,420 people registered, which is a record for webinars here. I think this is a very clinically relevant topic, and that's why we have so many people online. So really, with no further ado, I want to turn this over to Lorenzo, who's going to give us this first talk. And I want to remind the audience, please use the Q&A to send us questions. We're going to be stopping intermittently through the webinar, and we'll try and answer as many questions as we possibly can. So Lorenzo, the stage is yours.
Hi, everybody. This is really a pleasure for me to be part of this webinar. I frankly believe, Ian and Sandra, if this night there are so many participants, very close to 1,000, is because all of us remember as a nightmare the first nights on call, always scared of receiving a wake-up call from the emergency department telling us that there is a massive bleeding in cirrhotic patients. So, unfortunately, as you know, sometimes the nightmares come true. And 5 minutes earlier, you were in your bed, and then you finally are literally covered by blood inside this disaster. And while you try to answer to vital questions such as how, when, and why you decided to be a gastroenterologist and an endoscopist, you also try to remember what you should do to try to manage this bleeding. And while you are in the stomach of the patients and try to do your best, sometimes a thought comes in your mind. If only I had read the latest ESGE guidelines on the management of variceal bleeding, maybe I could know how to manage this disaster. So I want to tell you the truth. This is your lucky day, because not only you are still on time to read the latest guideline on the management of variceal hemorrhage, but you're also so lucky that tonight in this webinar, you have the leader of this guideline, Professor Gralnek, that will answer all your doubts and questions at the end of this webinar. So please stay tuned until the end. So before the endoscopy, we have to do just few things, but we have to do all these things in order to improve the outcome of our patients. First of all, we have to be sure that the hemodynamic status of our patients is correctly assessed, and then the patient is stabilized. If the patients need to a stabilization, then please invite your anesthesiologist to use the crystalloid fluids and to avoid the use of fresh frozen plasma, because it has been shown that fresh frozen plasma transfusion might significantly increase the mortality, the rebleeding risk, and the hospital stay of our patients, as well as the use of recombinant factors such as 7 and 10 has been shown that does not improve the outcome of our patients. So they are useless in this setting. Once you have stabilized your patients, then you go to another important issue. Should we intubate all our patients with bleeding and cirrhosis? So the answer is definitely not, because if we don't strictly select our patients, overall the mortality of patients is increased. So we have strictly selected the patients. When we should think about the intubation, first of all, when you have a high suspicion of an ongoing bleeding in these patients, also in the case in which the patient is already on encephalopathy, is in an agitation status, and also has an inability to control the airway. And once you have intubate your patients, then the extubation should occur as soon as clinical safety following upper endoscopy, because by this way, you do not increase the mortality of your patients. So go straight to the transfusion strategy. We have to be clear about the platelet transfusion. ESGE does not recommend routine platelet transfusion, neither has been fixed a threshold under which trigger the platelet transfusion. This is because it has been clearly demonstrated by thromboelastography studies that most of the cirrhotic patients maintains an efficient hemostatic competence. So most of cirrhotic patients do not need any platelet transfusion. When we think about the blood transfusion, if the patient is stable, then we have to go further to the his or her cardiovascular history. If the patient has no history of cardiovascular disease, then we should adopt a strict restrictive strategy and consider to transfuse the patients only when the hemoglobin threshold is below the 7 grams per deciliter, and with the aim of reach a target ranging from 7 to 9 grams per deciliter. If the patients has an history of cardiovascular disease, then a more liberal approach can be considered. Why we should adopt this restrictive transfusion policy? Because there are a large number of studies very well done. I just report here one of the latest published in Lancet a few years ago. It has been shown that when a restrictive transfusion policy is adopted, then we reduce significantly the risk of death and also the risk of rebleeding without any difference in the risk of ischemic events. So please, this is a strong recommendation from our guideline, and please adopt this transfusion strategy. Another important issue is to use the vasoactive agents. You can use terlipressin, octreotide, somatostatin up to 5 days. This is very important. Also in this case, we have a strong recommendation because it has been shown that if you infuse this vasoactive agent, you significantly reduce in-hospital and overall mortality, you reduce the rebleeding risk, the transfusion requirement, and most importantly, get your life easier because you are more because the control of recent bleeding is easier achieved. These are the drugs and the dosages. I just suggest you to get familiar with at least one of these drugs and go for it. Another important drug that we have to use before the endoscopy is the antibiotic prophylaxis. This is very, very important. We have to use ceftriaxone 1 gram per day for up to 7 days, because this is clearly demonstrated that there is a reduced overall mortality, risk of bacterial infection, and also rebleeding risk, as well as the hospital stay. We have also some data about a shorter regimen, just 3-day treatment regimen that may be sufficient. We don't have enough data for a strong recommendation. Maybe in the next guideline, this issue will be revised, but at the moment, 7 days should be considered the standard. So if you want to clean up the blood from the stomach, there is a strong suggestion to the use of prokinetics drugs. In particular, we have a lot of data that erythromycin should be used 250 milligrams intravenously in the absence of contraindication. But you have to remember that this drug should be administered at least 30 minutes before endoscopy. Since erythromycin is not always worldwide available, a second choice, even if we don't have so good data as for erythromycin, is the use of metoclopramide. And also in this case, we have a strong recommendation from our guideline. Just few words on the management of antiplatelet and anticoagulant therapy. So I just invite you to consider another ESGE guideline recently published that is focused only on this topic. But overall, consider just few words to say that obviously we have to temporarily withhold these drugs, and in the case of hemodynamic instability and anticoagulant therapy, an appropriate reversal agent should be used. Then we have the the big question, when should this drug be restarted? So it's always a matter of a balance between the thrombotic risk and the rebleeding risk. Generally speaking, if you are on anti-aggregant drugs, then you can restart it within 5 days, or if you are in anticoagulant, then you can consider a range between 3 to 7 days according to the thrombotic risk. I also invite you to have a talk with your cardiologist about this management. So the last issue, this is very important. How many hours should go by from your wake-up call and this massive bleeding? So ESGE guideline has fixed 12 hours, so the gastroscopy should be performed within 12 hours from the presentation and should not be influenced by the NR of the patients. Obviously, this can happen always after hemodynamic resuscitation. So once we have done these few things, but very, very important to improve the outcome of the patients, also to do our job in an easier way, then we are ready for the action, and then we can go for endoscopy. So Sandra, it's up to you.
Lorenzo, thank you very much. It's a very nice overview of what we really should be doing and the considerations that need to be made prior to performing the endoscopy. There are a few questions that have come in. So Sandra, before you start, let's talk about these questions very, very briefly. Lorenzo, I think you had talked about this. Somebody was asking about, does there really need to be a specific INR level that we want to get to prior to doing endoscopy? Now, when I was in training, we always talked about that you wanted to have an INR of at least 1.5 or less, but that's really not true anymore, is it? Maybe you want to elaborate on that.
Yeah, absolutely. So I have already said we should, the ENR level should not influence our ability to perform, to propose a gastroscopy. Absolutely no, because INR level does not mean that the patient is without an effective and efficient coagulation status. This is has been clearly demonstrated. So these cirrhotic patients maintain always a sort of coagulation state. So we should not consider and give too much value to ENR level before endoscopy. Absolutely not.
Okay. Sandra, there's a question here about antibiotic prophylaxis. Do we need to do that in patients without ascites?
Actually, it's recommended that we should use in all situations where we suspect variceal bleeding, and when we encounter variceal bleeding, we always should treat patient with antibiotic prophylaxis irrespective of ascites, and just because these patients are at a high risk of aspiration, so to prevent a further infection and probably sepsis afterwards.
Yeah, exactly. And also, we don't always sometimes realize when there's ascites. If it's a small amount of ascites, we may not even be able to detect that, certainly on a physical examination. Another couple of questions. Metoclopramide. Somebody's asking, is that contraindicated in patients with cirrhosis? To be honest with you, I don't think so, but I'm not 100% sure, but it's only one dose. We're not putting these patients on recurring prokinetic agents. So I'm going to tentatively say it would be safe to at least give one dose of metoclopramide if you don't have erythromycin available, because sometimes that's a problem. And Lorenzo, I'm going to jump back to you in regards to the restricted blood transfusion policy. Somebody's asking, does that really mean anybody who's had a cardiovascular history or just somebody who has recent cardiovascular history?
This is a good question, but so it's the patient has an history, generally speaking, of cardiovascular disease. You have to take it into account. Absolutely, yes. So restrictive policy is only if you don't have any cardiovascular history. This is very important to keep in mind. Absolutely, yes.
There's a lot of questions. Somebody's asking about tranexamic acid. Is that indicated? Is it useful? I'll answer this question very simply. No, it's not indicated. It's not useful. There's the HALTED study that was published a couple of years ago, very large international randomized trial that showed that tranexamic acid in GI bleeding did not provide any benefit. And actually, there may be detriment in giving this medication. So no, we should not be using that in this population. IV PPI, should we be giving an IV PPI? Sandra, do you have any thoughts about this? If you're suspecting, if you're really not sure, or if you really think it's suspected variceal bleeding, what would you do? Would you put them on an IV PPI prior to endoscopy?
So, I mean, it's not wrong if we first apply PPI, because even if we suspect variceal bleeding, it might be an upper GI bleeding from an ulcer, so it might be not wrong to apply PPI, but as soon as we identify the variceal bleeding, then we can stop PPI.
Okay, I agree with that. The biggest thing is making sure we stop it if we don't really need it. In fact, within the guidelines, it's really not recommended to continue patients on PPIs even after band ligation or treatment, because there's some data to show it may have a negative effect in cirrhotic patients and be detrimental. Okay, there's some questions about just the actual treatment now of acute bleeding for esophageal and gastric varices. So I'm going to turn this over to you, Sandra, who's going to talk about that specifically.
Okay, so now we will learn about how we actually manage esophagogastric variceal hemorrhage, and I will also focus on some tips and tricks. Actually not working right now.
There we go, I think.
Okay. So,
are you able to control it?
Okay. Okay, try again. Okay, so first of all, we have different classification system of esophageal varices, which are more or less complicated. So it is recommended to use the Baveno classification, which distinguishes esophageal varices into small, medium, and large varices. And we know that there are three major factors that tell us what the risk of bleeding is. And this is the size of the varices, the liver dysfunction, and if red signs are apparent at the varices. So I want to introduce you some technical tips and tricks based on some cases. So this is a 52-year-old male with an alcoholic liver cirrhosis, and he was admitted to the emergency department with an onset of 3 times hematemesis and a syncope 2 hours ago, and he appears with a mild jaundice, and the HB level was at 7.1. And when we performed endoscopy, this is what we see. We see a lot of blood, and when we slowly withdraw the endoscope, we see here this oozing vessel at the 1 o'clock position. And that's always, or sometimes also the difficulty. We see a lot of blood in the stomach, we see a lot of blood in the esophagus, so it's kind of difficult to identify the bleeding vessel. So we should use a gastroscope with a water jet capability to clear the vision and carefully inspect, really decide that it comes here at the 3 o'clock position when we see the bleeding vessel. And when we want to treat esophageal variceal bleeding with endoscopic band ligation, we should also know how to set up a band ligation. And this we can see in this short video. These components include a multi-band ligator handle. Then we also have a loading catheter, a barrel with preloaded bands with an attached trigger cord and irrigation adapter. And first of all, we insert the the handle on the endoscopic channel, and then we insert the loading catheter into the accessory channel. This can be sometimes difficult, so maybe we first have to pierce it, and then we can introduce it until it exits the end of the scope. And then we attach the cord to the hook at the end of the loading catheter, and you draw the loading catheter and the triggered cord up through the endoscope and the handle and pull it back until the node is seated into the hole of the spool of the handle. And then you also attach the barrel on the tip of the endoscope, ensuring that the barrel is advanced on the tip as far as possible. And with the handle in the two-way position, you slowly rotate the handle clockwise to wind the trigger cord on under the handle spool till it is tight. And then it is also important that you see that you do have two features of the handle. It has two positions which can control the rotation. You have a firing position, which allows the handle to be rotated only in a forward direction. And then you have the two-way position, which allows both ways. And before you introduce the endoscope, it is also important that we should control the suction function. And one important thing before we introduce the endoscope for ligation, that we check the endoscopic view. So to optimize the vision, it is very important that the trigger cord may be altered by rotating the barrel and should be placed in an 11 and 5 o'clock position, because there we have the best visualization. And we also should ensure that the trigger cord does not become pinched between the barrel and the endoscope. And before we introduce the endoscope inside the patient, it is recommended that we keep the handle in the two-way position. And as soon as we identify the bleeding vessel, then we can put the handle into the firing position, and then we localize the bleeding. We try to position the bleeding vessel in the middle of the cap. We apply a lot of suction, and then we deploy our first band by rotating the handle in a clockwise position. But even if you don't find any active bleeding varix, then we have to carefully inspect our varices for signs of recent bleeding, such as wide nipples or overlying clot, because these would also be the sites where we first deploy our band, and then we go upwards in a circular manner. But if we see red signs such as red wall markings, cherry red spot, hemocystic spot, varices on varixes, then these indicate that bleeding might occur. And like in this patient, where we see really large esophagus varices, which extend over about 2/3 of the esophagus, and we see a lot of red spots, varices on varices, which indicate that these varices are or might be bleeding. And in these cases, we start as low as possible with our band ligation. We start at the GI junction, and then we work our way up, usually in a circulate manner, and we try to cover each varix at least with 2 to 3 bands. And to summarize here some technical aspects of the endoscopic band ligation. So you should use a diagnostic size gastroscope with a water jet capability. In case you have an active bleeding, then this is the site which we treat first. Otherwise, we start at the GI junction, and what we want to achieve is the complete readout sign. Therefore, we apply a lot of suction, and if we don't achieve the complete readout side, then we can also release it and go for another attempt. Suction should be applied until the band is completely released, and we can also use rotation maneuvers. We can maneuver the endoscope back and forward just to get as much as tissue into the cap. And it seems that additional 6 bands, more than 6 bands per session is not beneficial. It only takes longer, and it also has there are no data that any of the different devices available are any better. So the endoscopic band ligation is the recommended treatment for the acute esophageal variceal bleeding, and endoscopic band ligation is also used for primary and secondary prophylaxis because it is superior to sclerotherapy. Sclerotherapy is only recommended if endoscopic band ligation is not available or if it is technically difficult. So when we have achieved an hemostatic if we have control the bleeding, then what should we do next? We perform secondary prophylaxis, and then we have to decide if we have a low risk situation or if we have a high risk situation for recurrent bleeding. A high risk situation is defined as a type C class or type B class with more than 7 points, with an active esophagogastric hemorrhage at the time of endoscopy despite vasoactive agents, or a hepatic venous pressure agent of more than 20 millimeter Hg. And in these high-risk situations, a preemptive TIPS within 72 hours is recommended because it has shown that in these high-risk patients, also we have achieved acute hemostatic by endoscopic band ligation. These patients benefit from an early TIPS in terms of rebleeding, the chance of eradication, the mortality, and the survival as compared to endoscopic band ligation and beta blocker. But if you don't have a high-risk situation, just a low-risk situation, then we continue with sessions of band ligations every 2 to 4 weeks until the esophageal varices are eradicated, and we combine this with non-selective beta blockers such as carvedilol, propranolol, and nadolol, because the combination therapy shows to reduce the recurrency. So the next case is also a female patient with a diagnosis of alcohol and liver cirrhosis, and she has no history of GI bleeding, and we perform a screening EGD. But before that, we should remind ourselves who we should screen for esophageal varices. And there the new guidelines give us very clear recommendations. They say, in case of a decompensated advanced chronic liver disease with a liver stiffness measurement of more than 20 kilopascal or platelet count below 150 patients, these should be screened. Also, patients with a compensated advanced chronic liver disease with either a liver stiffness measurement of more than 20 kilopascal or platelet count below 150 were not receiving non-selective beta blockers, but we can avoid endoscopy for those patients with a liver stiffness measurement below 20 and with platelet counts of more than 150. And what can we use for primary prophylaxis? We use non-selective beta blockers, preferable carvedilol, because it has shown to lower greater the portal pressure. But endoscopic band ligation is also possible, but it is important to know that we prevent bleeding only in high-risk varices, such as medium to large varices or small varices with red signs. And it used to be that endoscopic band ligation and non-selective beta blockers were equal, but recent data show that the administration of beta blockers may be even beneficial also in small varices to reduce the chance of complication, including bleeding. But lastly, the choice of treatment is, of course, based on the local resource, the expertise, the contraindication, and some adverse events. The next case, also a patient with liver cirrhosis. She was 1 week ago at the hospital for variceal bleeding, which was treated by band ligation, and now she presents again with severe recurrent bleeding. And this is a situation which can occur after band ligation because band ligation induces ulcers. Usually these ulcers are shallow, but sometimes they can be quite deep and provoke bleeding, which is associated with a high mortality rate. And unfortunately, the use of PPI does not seem to prevent this complication. It only reduces the size of the ulcer. And in our last case, this is now a 48-year-old male with an advanced chronic liver disease, and he received an emergency endoscopy one day before with a bind ligation of esophageal varices, and now he presents again with hematemesis. And here we see we are in a retroflex position, and now we see an active bleeding from a gastric varice. We know that gastric varices bleed less frequently than esophageal varices, but are more severe and associated with a higher mortality. And if we remember the classification of gastric varices, we use the Sarin classification, which divides gastroesophageal varices into type 1 and 2, which either extend below the cardia into the lesser curvature or below the cardia into the fundus. These are the most frequent ones. And then we can also see isolated varices in the fundus or isolated varices elsewhere in the stomach. And we have to know that gastroesophageal varices which extend into the fundus or isolated fundus varices are those with the highest risk of bleeding. So in this case of gastric varices, we use a different modality of treatment. We usually use a 21 gauge needle, and we perform an injection of a mixture of glue and lipiodol. We are here in a retroflective position, and we will now see how we pierce the vein. And then the nurse will rapidly start to inject the glue with the mixture of cyanoacrylate and lipiodol, and then she will flush it with another portion of lipiodol, and then you can pull the needle back, and you have to wait for a couple of minutes until the glue starts the coagulation. So in gastric or gastroesophageal varices, tissue adhesive is recommended for acute bleeding, which is a cyanoacrylate, and only in gastroesophageal varices type 1. These can also be treated with endoscopic band ligation, but in these cases we have to be careful because bands can drop and they may cause ulcers which can be deep and which can be bleeding, and this is often very difficult to handle. So here are also some technical aspects of a cyanoacrylate injection, because this is a kind of tricky, not only for the physician, because he has to work in a retroflex position, but also for the nurse, because she has to combine a contrast agent, lipiodol, with the glue, with the cyanoacrylate to prevent premature hardening. And she does this in a 1-to-1 portion mixture. So you need an experienced nurse, and usually you use a regular injection needle. You flush the needle with lipiodol, and then you install the mixture of lipiodol and glue, and you puncture the vein, and after you inject a bit more of lipiodol. We also have alternative endoscopic management modalities for gastric variceal hemorrhage, such as thrombin, for example. Thrombin compared to a cyanoacrylate injection has shown equal efficacy. In one study, there has shown that there's a higher complication rate with glue injection, but this might be due to an over-injection, which might have caused ulcers. But anyway, there are, of course, adverse events following a cyanoacrylate injection. Usually these are mild, but sometimes embolism may occur. And another treatment modality which might prevent these adverse events is the endosonographic guided coil and glue treatment for gastric varices, where you, under endosonographic guidance, you puncture the gastric varices and you embolisate that with coil and a cyanoacrylate. And the possible advantages of these methods is that you can directly visualize the vessel and torture this. You can inject directly into the vessel. You also can use a color doubler to identify the vessel and confirm the vessel is obliterated on a lack of flow post-intervention, so you don't need a direct endoscopic visualization, which is often impaired in gastric variceal bleeding. and you have the ability to target even deeper vessels leading to the bleeding site. So this is an example on an endosonography where you can see nicely these large gastric varices. And you can also measure how superficial these varices are. And under endosonographic guidance, here you see the Doppler bill. You can puncture these from the left corner. You can enter directly into the varix, and then you can deploy some small coils under X-ray control. And you can apply not only one coil, but various coils. And after you deploy these coils, you can also inject a small amount of glue. And then you can see nicely that you achieve the complete obliteration of this varix in this case. And you can also control this under Doppler contrast, where you can see no blood flow. This technique seems to be very successful, and it is also it also achieves high obliteration rate of the gastric varices of more than 90%. And even if you don't achieve it, you can retreat it. And in terms of adverse events, the most common adverse events was pain. If you use endosonographic guided management, you can do it either with coils alone or in combination with coils and glue injection. And the combination therapy seems to be beneficial in terms of the rate of adverse events, the rate of reintervention, and the rate of rebleeding. And this is a study showing, or meta-analysis showing, that the efficacy and safety of endoscopic ultrasound-guided therapy versus the direct endoscopic glue injection is preferable in terms of complete gastric obliteration and in terms of varix recurrence. So after we have controlled our gastric variceal bleeding, then we also perform secondary prophylaxis, either with additional glue injections 2 to 4 weeks after, and with non-selective beta blockers. And upon patient factors and local expertise, we can also use endosonographic guided coils, a cyanoacrylate injection, TIPS, or BATO. But what do we do for primary prophylaxis? That means that we have a patient where we identify these large gastric varices, but this patient has no history of bleeding and also no signs of bleeding spots or white nipples. So the problem is that most studies are performed for secondary prophylaxis, but this study is one for primary prophylaxis. A randomized controlled trial show comparing the treatment of gastric variceal bleeding either with a cyanoacrylate injection, beta blockers, or with no treatment. And it showed that the group of patients with a cyanoacrylate injection had a higher bleeding-free rate compared to the other two groups. But if you look at the survival rate, there's no difference in the three groups. So for primary prophylaxis, we would use non-selective beta blockers, and only in those patients unable to receive non-selective beta blockers, endoscopic treatment can be considered, but this is upon local expertise. So, but now I think we learned a lot about the endoscopic management of esophagogastric variceal bleeding, but now I'm keen to know what we should do if endoscopic treatment fails.
Okay, so Sandra, really nice talk, some great videos, but get ready because there's a ton of questions that will take about 5-10 minutes here. We're going to get to the whole issue of what happens if endoscopic therapy fails, and we're going to go back to Lorenzo's for that. So I'm going to try and group some of these questions together, Sandra, because some of them overlap. How do you, some people are asking, well, how do you prevent damage to the endoscope, whether it's the EUS scope or a regular gastroscope, with the use of glue? What are your practices so you don't ruin the scope?
I think it's important that you don't get the needle close to to the endoscope, and that you don't apply suction, even if this is difficult in some cases because we are used to apply suction, but then we just switch off the suction, and I think this is possible.
Okay, some very practical questions here, some of which we really don't have evidence, and this is going to be art, not science. So when you give Lipiodol and Histocril, you do it in a 50-50 combination, is that correct?
Yes.
And it says how much are you injecting of this in one session for gastric varices? 1 cc, 2 cc's, 10 cc's? What's your usual practice?
So usually we use 1 milliliter of cyanoacrylate and 1 milliliter or 0.7 milliliter of Lipiodol. And first of all, with about 0.3, we flush the needle with Lipiodol. So you have a mixture of 1 to 1.
Okay, somebody's asking, can you substitute 20% dextrose instead of the Lipiodol?
I never used it, so
I've never used it.
I don't have any experience on that.
Either do I. Lorenzo, any experience with that?
No,
I think you're on mute.
not,
Okay.
absolutely not.
Okay, a lot of questions about managing post-band ligation ulcers. And I understand why. I mean, people are worried about it. PPIs may not really be effective. They actually may be contraindicated in patients with cirrhosis. What do you guys do? Somebody was asking, would you use sucralfate? What do you guys do in your situations?
Well, this can be difficult to manage, actually. Well, you can try to perform another band ligation on the ulcer, if it is possible.
If it's bleeding.
If it is bleeding, yes.
What are you doing? Do you give anything to patients? Let's say you're banding esophageal varices. Are you putting them on some type of an acid suppressive medication afterwards?
No, not routinely, no.
Okay, Lorenzo, you're not either.
No, absolutely not.
Okay. We're not either. I don't know about sucralfate, and I don't know if there's any contraindications. If you are going to use sucralfate, my recommendation would be to crush it and mix it with about 30 cc's of water. So it's a slurry, and have them drink it that way, not just take the pill. But sucralfate usually has to be taken 3 or 4 times a day, which may be difficult. Let me see some other questions here. Use of stents. Well, I think you're going to get there, Lorenzo. We won't get there. That's coming up. Hemospray is coming up. Just sort of the role of, someone was asking about the non-selective beta blockers. What's the beta blocker of choice? What are you using? A lot of times it's the hepatologists that are dealing with this and not really us, but they're asking about carvedilol versus propranolol versus something else. What's your practice, Sandra, and then Lorenzo?
Actually, you can use what you have at your hospital, but carvedilol seems to have more effect to lower the pressure. So in my unit, we use carvedilol. Yeah,
this is the trend to switch to carvedilol. Yeah, because we have more evidence in the last years about this drug. So this should be the first choice.
Somebody was making a comment here that they actually use 40% dextrose instead of Lipiodol, and they flush that through, and then they inject the varix that way. I'm not sure if there's evidence about that, but they say it works well. Let me see. We still have a couple of minutes, I think, for questions. There's just a ton of questions here. Somebody was asking, Sandra, if you're going to be using EUS guided therapy for gastric varices, coiling and glue combination. Do you have to perform a Doppler afterwards to look at how successful you were with your therapy? Is that routinely done?
I think that's the advantage of sonography guided coiling and injection of glue, that you see directly the effect of your work, and you can control if the varix is completely obliterated. So that is definitely an advantage.
Okay. Somebody saying thank you to Sandra. You gave a great talk, so they're very appreciative of that. So good job. Somebody's asking about if you have a GOV2 varix, would placing a band at the GE junction, could it increase the risk of gastric variceal bleeding?
Mhm. Yes, I had the same experience that there was a patient with esophageal varices and also extending over the greater curvature into the fundus. And the patient first was seen with esophageal varices, and they were treated with band ligation. And at the first point, there were no signs like white nipple at the fundus varices. But then he administered again some days after, and he was actively bleeding from these fundus varices. So yes, I think we can increase the pressure at the fundus, and maybe we should go for preemptive tips in these kinds of patients.
Do you agree with that, Lorenzo?
Absolutely, yes. I had the same exact experience of Sandra. And I was the cause of a gastric bleeding after banding a GOV2 with banding. So the same as.
Okay. Somebody's asking about a patient's had esophageal variceal bleeding. We've placed bands. What do you do about a nasogastric tube afterwards if they need to be fed? Is it safe to place a nasogastric tube after that? How long do you wait to place a nasogastric tube after band ligation of esophageal varices? Lorenzo, I'll let you take the first shot at that question.
I frankly believe that you have to really balance the benefit of put a nasogastric tube if you don't have any alternative. I think you have always an alternative, at least for the first 2 to 3 weeks. You can do without an enteral tubes.
So what, you put them on PPN or TPN if you have to?
Yeah, absolutely. Okay. For at least 3
Sandra,
weeks.
what do you think?
Okay, if there's no urgent need for gastric tube, I would not do this just in the next 2 or 3 weeks after endoscopic band ligation. If you have any reason doing it, then I would do it under endoscopic control, but using a small tube. But I think, yes, you can avoid this.
Okay.
It's no need for it.
Okay, I think you may have mentioned this, Sandra, in your talk. Somebody says, what if you find a nipple sign a couple centimeters away from the GE junction, will you apply the band below the nipple or directly on the nipple?
Well, the white nipple is a sign of a bleeding that has occurred. So I would apply the first band on the white nipple and then go upwards. If it is possible afterwards, you can try to put another band below that, but the first band goes where the white nipple is.
I agree with that. I think if you see either active bleeding or if you think it's the actual stigmata of where it had been bleeding, that's the first place you need to put your band.
Absolutely.
Last question. We don't really talk about this. Hypertensive, portal hypertensive gastropathy. What do you do if they're bleeding? Usually it's oozing bleeding. It's usually not massive bleeding. You sort of have to treat the underlying disease is usually the problem. I guess if you have diffuse oozing as maybe a temporizing measure, you could use a topical agent, but any thoughts from you two?
We usually don't treat that.
Yep. I agree. Usually it's not massive bleeding. It's usually slow oozing bleeding and maybe patients presenting with iron deficiency anemia. Okay, let's switch back. I'm going to hand the mic over to you, Lorenzo, and Lorenzo's going to talk about, well, what happens if endoscopic hemostasis is just not working and failing? What are the other options available? So Lorenzo.
So dear friends, once again, we have done our gastroscopy. We have done all the right things that Sandra was told us, but so the patient still continue to bleeding, or there is a rebleeding soon after we finish our endoscopy. So first of all, I invite you to don't panicking. So take a deep breath. If you have done, if the patient, you have to check if the patient is on vasoactive pharmacological therapy and you have done all your possibility with the endoscopy, then please don't panic, because you don't have only one option. You have at least three options to consider. And in the next 10 minutes, I will just briefly show you each of these options. So the first one that should be your first choice is to consider an urgent TIPS. So the placement of a shunt between the portal system and the inferior cava vein. This is radiological techniques that with several aims that we will see later. First of all, I want to show you a brief video provided me by my friends, Dr. Lorenzo. In this case, the first things that you have to do is to measure the portal pressure gradient. In this case, it was very high, about 21 millimeter of mercury. Once you are inside the portal vein, then you inject your contrast, you show the clear presence of, here on the right on the screen, of huge varices, and then you proceed with the shunt. Just deploy the fully covered metal stand, then you go inside again, you inject, and then you show that the varices are disappeared. And most importantly, you have to check if you were successful, which means if you have a significant drop of the portal pressure gradient, as in this case. So just to be clear, if you want to be sure that you are successful, you have to have these images before TIPS and then after. As you can see on the right side, there is the complete and immediate detention of varices. So this was successful. So if you are successful, the outcomes are very, very good, with a technical success up to 95% in expert hands. However, we have to be clear that the 6 and 12-week mortalities, as well as the rebleeding risk, are not negligible. So the main risk factor that has been linked to this worst outcome is if we fail to achieve an adequate reduction of the portal pressure gradient. And this can happen if there is an early stent occlusion or stenosis or a migration of the stent. Also, if we wait too much time before performing TIPS, if the patient stay too much time in the intensive care unit because maybe it's too severe, then this can worsening the prognosis of our patients. So go for it as soon as you can if you have this chance. So adverse events, you can experience stent-related adverse events and also procedure-related adverse events. The stent-related are almost frequent. We can have stent migration or early shunt occlusion that can increase the risk of rebleeding and mortality. But most important, we have to remember that these patients, since we have a reduction of the blood flow to the liver, then these patients can experience hepatic encephalopathy. This is most important to remember and also to say prior to the TIPS to the patients. We can also have procedure-related adverse event, most frequently fever, the days after the procedure, or hemophilia. But in experience and hands, if you send your patient to a tertiary referral center, these adverse events are almost infrequent. If you don't have this possibility to send your patients that night as soon as possible to the interventional radiologist, then you can consider to place an esophageal fully covered metal stent. This can be done under fluoroscopic guidance, but also on endoscopic guidance. There are new stents that can be put in place in a very easy way, just doing a few things. First of all, you have just to inflate the gastric balloon. And once this gastric balloon is inflated, you have just to pull it back until you feel the resistance of the GI junction. Once you are in place, then you can safely place your fully covered metal stent, and then the device can be withdrawal. So this is a very easy technique that can be usable in an urgent setting. And the result, if I have to be sincere, are quite astonishing. This is the result of a pooled meta-analysis in which all the main outcomes, technical and clinical success rates, are very, very high, above 95%. However, the advanced event are not negligible. About 1/3 of our patients can experience a complication, and the most frequently reported is the migration of the stent, also the ulceration after the withdrawal of the stent. So if we don't have the possibility to place a stent, then we can consider a balloon tamponade. On the left side, you have the most famous one, the Sengstaken Blackmore, but we also have two possibilities, the Minnesota tube and the Linton necklace. So the main difference between these three tubes are the number of the ports, which means whether or not there is the possibility of an aspiration from the esophageal sides, and also the sides of the gastric balloon that can go from 400 millimeter up to 600 millimeter in the Linton necklace. In this later tube on the right side, you can see that there is only the gastric balloon, which means that this kind of tube is indicated only in the case of gastric varices bleeding. So the technique, few steps that we should carefully follow. This is very important because otherwise we can also experience a very serious adverse event. First of all, you have to inflate with just 50 up to 100 millimeter of air the gastric balloon, and you have to be sure that the gastric balloon is inside the gastric lumen by X-ray if you have this possibility. Once you have confirmed that the gastric balloon is inside the stomach, then you can inflate up to 400 millimeter. Then pull it back until you feel the resistance of the GI junction, and then you just stop and watch what is happening. If the patients still continue to bleed, then go to the esophageal balloon, and then you can inflate it up to 25 to 40 millimeter of mercury. And then you would have to leave it, fix it, and leave it in place up to 24 hours. So the outcome are quite good, about 90% of success. The aspiration that you experience and observe are aspiration, pressure necrosis, but I think the most terrifying one is when you accidentally inflate the gastric balloon inside the esophagus. By this way, you can have the rupture and the perforation of the esophagus, and this can significantly increase the risk of death of our patients. So, which are the main difference between SAMS and balloon tamponade? As we have seen, SAMS can be left in place about 7 days. That gives us more time to organize a rescue strategy, for example, contacting a referral center for radiology intervention. It is definitely more comfortable for the patients because it allowed endoscopic and oral feeding, but obviously it is definitely more expensive than balloon tamponade. Do we have any comparative study? Yes, absolutely. We have a small randomized but well-performed study that compare the use of SAMS or balloon tamponade. And when we go the main outcomes, these are all of these outcomes are in favor of SAMS placement. So if you have the possibility to choose between SAMS placement and balloon tamponade, SAMS should be your first choice. However, if you don't have the possibility to send the patient to a TIPS, or you don't have experience with SAMS placement, or you don't have a Sengstaken Blackmore in your unit, you should at least, you should not still start crying, but if you have an hemostatic spray in your unit, then you can go for it. This is a small clip that was published in the masterpiece of Ibrahim Mustafa, published 4 years ago in Gastro. They use hemospray as a bridge therapy, so just to have few hours to organize a rescue strategy. So what to do in case of failure of management of gastric variceal hemorrhage? So in this case, we also have two opportunity tips. We have already seen, and BRTO. What is BRTO? It's the balloon occluded retrograde transvenous obliteration. Also in this case, we have to call the interventional radiologist, and through a vein access, generally the femoral vein, if the patient has, and this is the conditio sine qua non, a gastrorenal or splenorenal shunts, then we go through this shunt, then we inflate our balloon and obliterate by injection sclerosing agents the gastric varices. The technical and clinical success, as you can see, are very, very high, above 95%. Which are the main difference between TIPS and BRTO? So we have obviously technical differences, but two other main differences. The first one, we have to remember that when we put in place a TIPS, then the portal blood flow is reduced. That means that we can worsen the hepatic encephalopathy and also the hepatic failure. While with BRTO, the portal blood flow is increased, so we don't have any risk of hepatic encephalopathy, neither of dysfunction of the hepatic function. And another important thing to remember is when we are successful with TIPS, we have the marked significant reduction of the portal pressure gradient, while with BRTO, the portal pressure gradient may be increased. And so we can provoke a variceal bleeding from the esophagus. So we have to keep in mind this possible complication after BRTO. However, if we can choose for the treatment of refractory gastric bleeding from gastric varices, what should we choose? We have this comparative study in which all the main outcomes, the rebleeding rate and the survival rate, are in favor of BRTO. If you can choose, then go for BRTO. So, my friends, in conclusion, in case of failure, you just have no panicking because there is always an option. Be familiar with at least one bridge therapy, SENS, balloon tamponade, and also have in your unit at least one hemostatic powder. And most importantly, remember to be always very kind with the interventional radiologists because you might need to call them during the night. And thank you very much for your attention.
Thanks, Lorenzo, for another great talk. So now you can get ready because there's now a bunch of questions for you. We still have basically 500 people still online, which is fantastic. I want to thank everybody for showing up. So there's a number of questions here. So again, some very practical questions about balloon tamponade. Are you inflating with air or with water? And when you do that, how are you measuring the pressure so you're not inflating too much or not enough?
This is a very important question. You have always to inflate with air very gently. So I think the main issue is the gastric balloon, because if you are not sure to be inside the gastric lumen, you can have really the only very serious adverse events. Then you inflate with air very gently. If you are feeling a resistance, then you have to stop. You should always check with X-ray that to be sure to be inside the stomach. Then you pull it back and feel the resistance. This is the main issue, I think. Then you go through with the air until you reach your 400-350 millimeter, and then you stop. You start watching whether or not there is still bleed, because very frequently it is enough with the gastric balloon. You don't need to inflate also the esophageal balloon. Otherwise, you have to put a manometer inside the. You have to link it with the tube, the esophageal balloon, and then you can measure it. The pressure, and you go once again very, very slowly, and when you feel too much resistance, you have to stop.
Okay, a few questions about post-TIPS care. Are you putting patients on aspirin or anticoagulation to try and prevent stent occlusion after TIPS placement?
Absolutely not, because the occlusion is generally not due to a thrombose. It's generally due because there is a misplacement, there is a migration, or there is an occlusion, but so it's not generally due to a thrombosis, and this not reduce significantly the risk of occlusion. It's something that happens independently of aspirin use.
I agree with that. Sandra, do you agree with that?
Yes, it's the same. Our radiologists use for a couple of days, 2 or 3 days, just heparin, and afterwards we stop it and we don't continue with any anticoagulation.
Okay, Sandra, somebody's asking about stents. Ella stent, any type of covered metal stent, does it matter?
Well, we have this kind of Dennis stent, which is a self-expanding metal stent, and we can use it as a bridge ring procedure. We can leave it up to 7 days inside, but it is a bridging procedure, so we have to go back and withdraw it after 7 days. And yeah, it seems to be better than the balloon tamponade, and I think it's also easy to place it.
Okay.
Absolutely.
Lorenzo, somebody's asking about what about using a little bit of contrast in the gastric balloon so you could visualize it better? Do you do that? Does it help?
No, generally speaking, if you are confident with X-rays, so it is clear that there is the balloon with the air inside the stomach. It's very easy to find it. You don't need constant contrast injection.
Okay. And somebody's asking here about really sort of the benefit of BRTO, CARTO, PARTO as compared to TIPS for gastric varices.
I think we have some data. So the main reason, so there is a less experience with BRTO overall among the interventional radiologists, because this is not so frequently done as TIPS. So this is why this is they are not so confident, and you need the presence of a shunt as a gastro or spleen or renal shunt. This is not always present. So this is one of this is the contraindication to this procedure. But if we have clear data that BRTO is more successful than TIPS with fewer adverse events. So if you have the real possibility to choose between these two, you have to go for BRTO.
Okay. Sandra, you agree with that?
Yes, actually, our radiologists at our hospital, they just perform TIPS, so I don't have personally any experience with BRTO, but the data say what Lorenzo says. Yes.
Yeah. Somebody's asking about use of rifaximin routinely after TIPS placement. You putting patients on rifaximin?
No.
We're not. No. Okay. Actually, this is a good question, an oldie but a goodie. I'm going to give this to you, Sandra. So what if band ligation is not working? Why can't you pull out a sclerosing agent and try and inject the esophageal varices?
And inject
inject a sclerosing agent, so ethanolamine or tetradecyl. I mean, when I started treating varices, we didn't have band ligation. I was only injecting. What are your thoughts about that?
Of course, if endoscopic band ligation fails, this could be an option, but for the primary treatment, endoscopic band ligation has advantages and is the definitive recommended treatment as a first-line option.
Okay. There's more questions, but there's just there's too many. We've had over 100 questions, which is fantastic, and we had almost 550 people online at one time. This was really a great webinar. So before everybody runs away, I'm going to be at ESGE Days in Dublin. I know that Sandra and Lorenzo are going to be at ESGE Days in Dublin. If you haven't registered yet, I really think it'd be great for you guys to register and be with us at ESGE Days. Let me skip back one slide. Let me skip back another slide. There we go. No. right here. So ESG Days is going to be April 20th to the 22nd. There's live endoscopy. There's the ESG postgraduate course. There are guideline sessions. I wish I could tell you that we had hands-on training still available, but if you can believe it, it is already completely sold out. Both the basic hands-on training as well as the advanced. We're sorry, but we had a huge response to the hands-on training. You can see if things open up once you're there, but everything is full at this point. We are expecting a lot of people. We'd love to have you there. It's great networking, great lectures, great live endoscopy. If you are not a member of ESGE, we'd love for you to join. There's actually special packages. If you join and become a member, you get a discounted rate for coming to the ESGE days. So we'd love to see you there. I want to just say the next webinar on Wednesday is going to be March 15th. It's going to be a paper of the month series with Helmut Messman and Peter Searsema, as well as you see everybody else who's going to be there. I want to thank, of course, the ESG office, the governing board, the webinar teams, specifically Dave Inker and Gabby Varga, who do a great job with the webinar series. Without them, we could not pull this off. And I want to thank Lorenzo and Sandra. I think this was a great webinar. Lots of people, great information, great practical tips. And I want to thank everybody who joined. This was just a great webinar. So thank you guys again.
Yeah, thank you. Thank you very much.
Thank you.
Bye, everybody. Have
Bye.
a nice rest of your evening.
Bye-bye.
Bye-bye now.